Okay. Yeah. Good morning, everyone.
Good morning, sir.
Good morning, sir.
Welcome
Good
back.
morning, sir.
Good morning. Unfortunately, what I had predicted has come true. We are back to this. So, anyway, teaching has to continue. Today we will be going with part two of asthma, and yeah. Can you see the slides?
Yes,
Yes,
sir.
sir.
Okay. Fine. So we'll start with part two of asthma. Just a recap, there's been quite a small break between our first and second classes. So just giving you all a recap. Firstly, most important, the diagnosis. You have to understand that asthma, heterogeneous. There's symptoms of wheeze, shortness of breath, chest tightness, and cough. And the variation may be every day, or it may be different parts of the different times of the year. Okay, and then that intensity also changes. It may even change every day or different times of the year. And pathophysiology, again, there are multiple inflammatory mediators that take part. Important bronchoconstrictor mediators include your histamine, which is released by your mast cells, your endothelins, which are due to the activation of the endothelial cells. Okay, then the main effects produced by all this inflammation is bronchospasm, plasma exudation, mucus secretion, airway hyperresponsiveness, and structural changes, which we also call as airway remodeling. So airway remodeling is essentially the last stage. This is one part where we do not wish that our asthmatic patients reach. Our whole idea of treating them is to prevent them going into this stage of airway remodeling, because once we reach this stage, basically no therapy will be that effective. So what I want you to remember is the main effect, the primary effect which we can see as asthmatics behind all this inflammatory response is bronchospasm. That is one important thing, and because I would like to highlight that now, because we will be coming across that later on also. So diagnosis, again, most important diagnosis is your spirometry. You need and a bronchodilator reversibility. That means after giving salbutamol of 400 mics, you then repeat your spirometry and you note any improvement in FEV1. More than 12% and 200 ml minimum increase should be there for adults. In children, only more than 12% is good enough. Or if you have, you've given them, if they have their own peak flow meters, they can always see a change at more than 20% change between different times of the day. That would suggest asthma. And FEV1 increase of more than 50% decrease with exercise. In addition to that, there's a number of other additional investigations that you can do. Your immunoglobulin E levels, your eosinophil levels, your CT scan if you're thinking of that the wheeze is due to some other cause, your chest x-ray as part of baseline investigation. So that we will not, they're not really that important, but of course, when you're thinking of a differential diagnosis, you're trying to rule out other causes, then yes, that is those added investigations are important. Okay, coming to management. Now, when it comes to management, basically we have the whole idea of why we want to manage these patients are, number one, we need to achieve a good control of the symptoms. We have to help the patient achieve a good control of symptoms so as to help them maintain normal activity levels. And by doing so, we minimize the risk of these patients from any asthma-related death, exacerbations, persistent airflow limitation, and side effects. Now, when we are treating asthmatic patients, of course, we have to understand that from our part, from the physicians, from the doctor's point of view, a good control may be manifested in a significant improvement in their FEV1, their FVC, that means their spirometric or lab values, the control of eosinophil counts, or the IgE levels are under control. That from our part is satisfactory enough as to define control. However, we must not forget that we must also take into consideration the patient's own emotions into their disease. So you have to understand the patient's goal. What do they want? What do the patients also want? So this is where your interaction with the patient is very, very important. Okay. Now, Achieving asthma control. What do we mean when we say asthma control of asthma? Basically, the level of asthma control is the extent to which the features of asthma are observed in a patient, or they've been reduced by or removed by the treatment that you have given. Now, asthma control has two domains. One is your symptom control, and one is the assessing the risk of future adverse outcomes. Okay. So when we look at asthma control, we often look after either at baseline and then after 2 to 3 months of treatment. When you've seen a patient in baseline, you've diagnosed a patient with asthma, you've given them treatment. That treatment, as much as possible, try not to modify, try not to change. Let them continue these treatments. Assess them in between with regards to their adherence, their compliance, and then reassess their symptomatology after 2 to 3 months. That way, we'll have a fair idea of what is their level of control. Now, this slide is probably one of the most important slides. This is how do we assess control, the level of control. So as you can see here, there are a number of symptom points here. Well controlled, partly controlled, and uncontrolled. Now, the most important thing here is when we ask the questions, we have to remember that we are looking at their most recent history. That is in the past 4 weeks only, in the recent 4 weeks. So what we ask is, do they have any daytime asthma symptoms more than twice a week? Daytime asthma symptoms can be anything from wheeze, from chest tightness, from breathlessness, from persistent cough, whether they've been having it for more than twice a week in the last 4 weeks. Another important is night awakening due to asthma. Either their cough is so, the nocturnal cough is so significant that it awakes them from sleep, or they are getting good sleep, but they are woken up because of breathlessness or because of wheeze. Then has there been a need for the patient to use their reliever medications for more than twice a week in the last 4 weeks? And lastly, has there been any limitation to their activities because of their disease? Maybe they've not been able to come to work. Maybe they've not been able to go to college, go to school. Or if you're a sports person, you have to skip practice, have to skip sports, have to skip your music classes. So if that is due to asthma, then yes, the asthma has contributed significantly. So if they don't have any of these symptoms, then it's well controlled. If they have one or two of these symptoms, then it's partly controlled. And if there are more than 2 symptoms, then we consider the asthma as uncontrolled. So this is the basic level of asthma control that we are talking about. So in addition to that, we have to also look at the risk factors. Now, risk factors for poor outcome, again, at the time of diagnosis, you can assess the risk factors, which I've highlighted in the previous class. Then another thing is having uncontrolled asthma symptoms is an important risk factor for exacerbations. So if your patient that you're following up is persistently having uncontrolled symptoms despite medication, then that is a risk for future exacerbations. Then now we look at potentially modifiable risk factors for exacerbations, even in patients with few symptoms. That is medications. If there's been a high use of short-acting beta agonists, then they've not used enough inhaled corticosteroids, because in asthma, unlike COPD, the cornerstone of therapy is inhaled corticosteroids, because, like I said earlier, inflammation is a major component of the manifestations of asthma, the disease itself. So the most important thing for them is not the bronchodilators, but rather the anti-inflammatory that they get from the inhaled corticosteroids. So not using enough inhaled corticosteroids, basically they're letting the underlying inflammation simmer in the lungs, which may then later on explode into an exacerbation. Look at modifiable comorbidities, obesity, rhinosinusitis, gastroesophageal reflux, food allergies, or even pregnancy. So all these can be modified. Obesity, you can ask them to work on that, increase their exercise, improve their exercise tolerance, change their dietary habits, exposure to smoking or allergens, then that is where you have to explain to them. Okay. Now, a lung function, just by doing their baseline lung function, you can also predict who are likely to have a worse outcome. If the FEV1 pre-treatment is very, very low, or if the bronchodilator reversibility is very high, it's almost 20 to 30%, then you know that the lungs are quite inflamed. The lungs are quite inflamed, then there's a higher risk of them of developing an exacerbation. Okay, and other risk factors include if in their previous exacerbation they've had such a bad one that they've required intubation or a visit to the intensive care unit, or they've been having more than one exacerbation in the last year. Those are all risk factors of future exacerbations. In addition to that, you have risk factors for developing persistent airflow limitation. Now, persistent airflow limitation is another major hurdle in the treatment of asthma, because one of the ways in which we are monitoring them is by doing your spirometry. So the patient may symptomatically improve, but if you're looking at his spirometric values, they're still not really improving to the satisfaction that the physician would want to. So this is persistent airflow limitation. Here, when there's a history of low birth weight in the patient, okay, these are all basically at birth or during childhood. There's lack of inhaled corticosteroid treatment for the asthma. This one I'll come to later on. Then there's persistent exposure to tobacco smoke. Then risk factors for medication side effects. Now the problem is, if you're giving systemic steroid for those, frequent oral corticosteroid use, you may have toxicity because of long-term steroid use. Okay, and then poor inhalative techniques. These all will contribute to the side effects that they can get because of their medications. So when we look at asthma medications, the basic drugs I've already covered it in your COPD lectures. Basically, you have your bronchodilators, you have your short-acting, long-acting, and medium-acting and long-acting. You have your muscarinic antagonists, and the most important class in the management of asthma, along with these inhalers, is your inhaled corticosteroids. Okay, so in asthma, we'll further classify them into two other subcategories. You have your controller medications. We usually call them your controller and your reliever. So your controller are what are your maintenance, something which you tell the patient to take on a daily basis, okay, which they should not miss, which you should not miss the dose. They are primarily used to reduce airway inflammation, to control the symptoms, and to reduce the future risk of exacerbations. So most of the time, these controller medications will either be a long-acting bronchodilator with an ICS, with an inhaled corticosteroids. Inhaled corticosteroids form the backbone of controller medications. Your reliever medications are those that provide an immediate symptomatic relief. So these are some of the medications that you tell the patient you must carry with you wherever you go. Keep this medication in your pocket. You can use them wherever you go. If you're traveling to, say, you're going out of the city, you're going to the villages, the road is dusty, the dust may precipitate your asthma, so you carry this inhaler with you for that time. So it's an SOS use. So these are reliever medications. Again, here, yes, you can use your short-acting beta agonists because they have a more rapid onset, but the duration of action is not very long. But nowadays, what the trend is that we still add inhaled corticosteroids to the reliever medication subgroup. Okay, and then of course you have your other add-on therapies such as your tiotropium, which is considered an add-on therapy. It's a long-acting muscarinic antagonist, but it is now being increasingly used in asthma, especially in those which are uncontrolled asthma, not getting relief with high-dosed LABA and ICS. So you have your tiotropium, then you have your anti-IgE, your oral corticosteroids, your anti-IL-5 therapies. So these all come under the premise of the add-on therapies for severe asthma. When we're talking of add-on therapies, we're not really looking at add-on therapies for mild asthma, moderate asthma, or even a partial or controlled asthma. Okay, so how do we go about, so the next question now that we have to ask ourselves is, what do we start for which patient? Okay, so supposing a patient comes to you with infrequent asthma symptoms, less than twice a month. You've taken the history, the 4-week history, and is more or less controlled or very or partially controlled. Here you can give as needed low dose ICS formoterol. ICS formoterol basically is your ICS and LABA. Formoterol is a LABA, long-acting beta agonist. Okay, so ICS LABA as needed. That means SOS. Okay, so this is when I show you the next slide, you'll have a better idea. Then asthma symptoms needing or need for reliever medications twice a month or more. Here you can continue with low dose ICS as needed, short-acting beta agonist, and for control you need ICS formoterol or ICS LABA. Then for the next one with troublesome asthma symptoms, on most days we have to maintain with ICS LABA, or you can only give medium dose ICS. But as you can see here, inhaled corticosteroid is mandatory, and as a reliever medication, you can use ICS LAVA. And for those with uncontrolled asthma and all, we have to start with high dose ICS or ICS LAVA, and of course you can add your systemic steroids and other therapies as and when required. Okay, so just remember this slide. I'll now show you the next slide, which is basically this is your GINA treatment protocol. Here, when we look at assessment, okay, you've confirmed the diagnosis, you've looked at the symptom risk. So symptoms, if it is less than twice a month, symptoms is more than twice a month, that is partially controlled. Here, these two are basically partially controlled, and here is also either poorly controlled, and step 5 is more or less almost uncontrolled and severe asthma. So as you can see here for step 1, that means more or less controlled at this medication. You have your preferred controller medication is as needed low dose ICS formoterol or ICS LAVA. Now what is mentioned here, as needed shorter acting beta agonist as SABA as your preferred reliever medication. We are now starting to do away with that. In fact, most of the guidelines now have gone against using only SABA. That means only aspirin or only your aspirin, your salbutamol, against using salbutamol as a reliever medication, because the underlying pathophysiology, like I said, of asthma is inflammation. But the manifestation of asthma is bronchospasm. Now, if you give only a short-acting beta agonist, you are treating the part which is being manifested. Correct. You are treating the bronchospasm. The bronchodilator will give symptomatic relief, no doubt, but the underlying inflammation is not taken care of. And if that underlying inflammation is not taken care of, then there's always a risk that he will have persistence of symptoms, or at worst, he may even develop an exacerbation. So that's why now the preferred reliever is a combination of ICS with a LAVA. Okay. So step 1, you can give SOS, ICS LAVA. They do not take it every day. They can only take it when they have their symptoms. So step 2 is you can advise them to take low dose of these ICS LAVA combination as a controller. That means this is something which they need to take every day. And then as a reliever, they can continue using the same medication, but on an SOS basis. So step 3 is similar to that, but you can increase the dose. If there's been no relief from step 2 medication, you can increase to a medium dose. And then from step 4, you continue with you can start off with a medium dose of your ICS LAVA, and again preferred reliever is ICS LAVA alone. And step 5 is where they present really at a bad state, where you need to give them high dose of steroids and bronchodilators. In addition, you can add tiotropium, then you can even add your oral steroids, then you can add your other medications, so your anti-IgE, anti-interleukin 5, and interleukin 4 receptors, and all that can be added here. Okay, now if you see here, what is common here is that ICS LAVA is almost universally being used from across the board, from step 1 all the way to step 5. So this was after a major study which was done in Canada way back in 2005, 2006. Then they came up with something known as the SMART therapy. So SMART is basically an acronym of the drug which they had used in that study, which is Symbicort for maintenance and reliever therapy. So what they've done here, this has basically revolutionized. In fact, this particular study has then led to the formation of these guidelines by the Asthma Society, where you have one drug, that is Symbicort, which is basically a combination of budesonide, which is an inhaled corticosteroid, and formoterol, which is a long-acting beta agonist, for both maintenance and reliever. So that way it greatly enhances the compliance of the patients, because they don't have to keep a separate medication for the reliever. They don't have to keep a separate medication for the controller. So all with one medicine, you can achieve both your controller and reliever function. So this is your SMART therapy. So basically, when you look at the GINA guidelines now also, from where I've taken this table, again, it is more or less a modification of the SMART therapy, where at higher levels you add on other drugs as needed. But for your reliever and maintenance, basically it's one drug, which is your ICS for withdrawal, and which is why, like I've said, using aspirin as a reliever medication is being discouraged now by most of the asthma societies. Okay, so this is basically provides a major framework, basically a skeleton from which you have to work with your patient on how to treat asthma. But most of the time now we have gone to a concept of personalized care. We have to individualize our care. And this is where a similar cycle you would have seen in your COPD, where you assess, adjust, and you review. You assess, you confirm the diagnosis, you look at symptom control, you see the inhaler use, the inhaler adherence, the inhaler techniques. Okay, then you adjust with either you step up or you step down. Okay, you may add on your non-pharmacological strategies that are such as educating them on the importance of secondhand tobacco smoke, quitting smoking, making sure that they remove any sources of dust from their houses, making sure that they stay away from pets and all that. So all this education comes in the adjustment part. Then of course you review. So it's an ongoing cycle. Your interaction with your patient will be continuous. Okay, so now when we adopt this into our step down therapy, then we know then it makes more sense in the sense that with each cycle, if we want to, we can step up or step down. Okay, so now that's the most important question now is, when do we step up therapy and when do we step down? How do we step up and how do we step down? So stepping up therapy, basically there are three forms. One is a sustained step up, where you have uncontrolled symptoms despite good adherence and correct technique, and you address your modifiable risk factors, then you consider such a step up as a therapeutic trial. So you've gone from step 2, you've increased your dose of your LABA ICS, or you've added your montelukast as a step up drug. Then the most important thing is, do not change this kind of therapy. Once you've stepped up once, don't change it. They can always use the same drug as a reliever, but as a controller medication, do not change. Once you made a change, allow at least 2 to 3 months in that particular class of treatment, then you review. Okay, then you review and then you see what is the adherence. How is the patient's symptoms, whether they've improved, whether they've not improved, then you can plan accordingly. So this is a sustained step up. Next, you have a short-term step up. A short-term step up is basically when you just for a few days increase your dose of your maintenance therapy, your ICS LABA. That is, say when they've had maybe a viral infection, or when season is changing, like as it is right now, where suddenly we are going from very hot, now we're getting the rains are coming, the monsoon is coming. So during this particular period when there's a change in season and all that, yes, your patient may develop symptoms. So in that time, you can always tell them that yes, you can either increase the dose or you can just increase the frequency. Say he's been taking his ICS LABA once a day only. Tell him, okay, now you can take it twice a day for this time for a week, see how it is. Once you've improved, then you go back to your once a day dosing, that kind of thing. And day-to-day adjustment is basically adjusting your SOS according to the symptoms. Say supposing a person has to go from Shillong, he's fine, he goes down to Guwahati where it's more dusty and all, he needs a symptom. So there he can use his SOS, and once he comes back, he'll be fine. So this is your 3 types of step up that you can do. Then coming to step down. Why do we want to step down? The reason why we want to step down is we want to achieve the minimum effective treatment for the patient. This will help to reduce the treatment cost for the patient, and also it will reduce the side effects. Remember that these drugs which we are giving, they are associated with a number of side effects. You would have recalled from the COPD, your Bronchial is associated with a number of side effects. Tachycardia, hypokalemia, cardiac arrhythmias and all that. Even your steroids can also be associated with a number of side effects. So that is why we need to we want to bring them down. Once they've achieved a certain amount of control, we try to gradually taper those medicines so that we can reach that level of medication, which is the minimum, but will still provide the good amount of control for them. So we start stepping down again, like what we mentioned for step up. After 3 months of stability in a particular group, then we start stepping down. So even after we've stepped down, we wait for 3 months, then we step down further. But what is most important to remember is we must, in asthmatics, we must never completely withdraw your inhaled corticosteroids, because inhaled corticosteroids, like I've said many times, it is the backbone of your treatment for asthma. So if we go back, you would have seen that in your chart, in the GINA chart, you would have seen low dose, medium dose, high dose. So what is that low dose, medium dose, high dose? So these are basically your dosages. There are two main components of inhaled steroids which we are getting here in the country. One is budesonide, which is available both as a DPI or a dry powder, and your fluticasone, which is available as both a dry powder and a metered dose inhaler. So a low dose budesonide would ideally contain 200 to 400 micrograms. A medium dose is 400 to 800, and a high dose would contain anything more than 800. When you're looking at fluticasone, low dose is up to 250 to 500 is medium dose, and anything beyond 500 micrograms per day. This is per day dosing. Anything beyond 500 is considered as a high dose. So, for example, if I did not bring my inhaler today, I could have shown you. But yeah, so if you look at Foracort, I will probably show you that. Okay. So next most important thing which we've come across these medications, we've talked about these medications in your COPD classes, we've talked about them we're talking about them now in your classes on asthma, but what exactly are inhalers and how do we use them? This is probably the most important part, which even if you don't remember anything from the lectures, what I want you to remember is, what I want you to take home is how to explain to a patient how to take an inhaler properly, because this is the most important thing. Every time, whether it's a COPD patient or your asthmatic patient, the most important thing is how are they complying with the way they're supposed to take their medication? Because if the most common cause of exacerbations or in fact non-compliance is that they do not know how to take these medications. You'll just take down this inhaler. If nobody explains to the patient, they will not know how to take these inhalers. So inhalers also, they come in many forms. You have your dry powder inhaler. Basically these are single dose dividers where this is a delivery device and this is another delivery device. The medications will come in a capsule. You can put it here in the delivery device and then you can take them. Then you can have these as multiple dose devices here. You have like a disc inhaler where the dry powders will be in the form of small they'll be in the form of these, not exactly capsules, but they'll be in a chamber, and these chambers will then be loaded into these diskettes here. Okay, so these are multiple dose devices and single dose devices. Then you have your MDIs, metered dose inhaler. Why are they called metered dose inhaler? Because in these inhalers, every time you press, the amount of drug that comes out will be fixed. Even if I keep it depressed, it's not like a perfume bottle or your deodorant where the moment you keep on pressing, everything will come out. No, with one press, only a fixed amount of drug will come out depending on what is the dose. If it is a 200 microgram drug, then 200 micrograms will come out with each puff. Okay, so these are your metered dose inhalers, and then in addition to them, what we usually recommend now is that you use them with a spacer device. So this spacer device is basically a chamber to which these metered dose inhaler is attached. Because the reason is because I will show you the video on how to use these inhalers. Then I will explain to you what is the significance of using a chamber here. So now, in addition to that, metered dose inhalers have also come as a breath actuated. Now, breath actuated inhalers, MDIs, have mainly been developed so as to overcome the synchronicity that you need when using these MDIs without the spacer. Okay, so now let's take a look at Foracort. Like when we look at, I'll just go back. So just remember this particular. So this is Foracort 200. Okay, this is another example of a Foracort 200. This is manufactured by Cipla. So if you were to go back, a 200 dose. So if you're giving that 200 dose Foracort, if you're giving that one puff once a day, it is considered a low dose. So even if you go up to 2 puffs once a day, okay, so this is what we normally advise. 2 puffs once a day is a low dose of ICS. Okay, now if you increase that, say you increase it to 2 puffs twice a day, so your total is around 800. that comes to a medium dose. So if you were to increase that to almost 2 puffs 3 to 4 times a day, that comes to a high dose. So that is how we calculate our low dose, medium dose, and high dose of inhaled corticosteroids. Okay, so like I said, so these are breath actuated MDIs. And then we come to nebulizers. So nebulizers, you can see this is a machine here. There's a nebulizer machine. This is what we call as a jet nebulizer, because what this machine does is that here there is a motor here which creates a stream, a powerful stream of air which pushes through this tubing and generates and into this chamber, where there's a small nozzle here. Basically, it follows a Bernoulli's principle, where there's a small nozzle, and that nozzle, because the air is forced through that, it creates a lot of turbulence. So that turbulence then sort of nebulizes the fluid which is present, and that you get this steam. So this is a conventional jet nebulizer. This is very common. You see it everywhere in our wards. Now, of late, we've had nebulizers that are of a different technology. We call them the mesh nebulizers, and the advantage of these is that they are very small. As you can see, that they're almost the size of an inhaler, but it's actually a nebulizer where there's a vibrating mesh. It's very silent, and it produces an equal amount of nebulized mist, and the drug is placed here. So these advantages that they are battery operated and they are chargeable, but either they come as battery operated. Sometimes they come with a chargeable USB. So it's very user friendly and pocket friendly, and you can actually carry this nebulizer in your pocket. You don't even in place of your metered dose inhaler. Okay, so these are the different types of inhaled medications or devices through which we give inhaled medications. So now that you've identified them, the next important thing is we have to see that the patients are taking them correctly. Okay, so how do we do? A classic example is this. Now let's just watch this. This is from the house. Okay. How do I pause this? So basically, if you see that lady, she says that she goes through almost one inhaler device a week, which is a very high dose. So that's why even Dr. House was a bit bemused, because if somebody were to use such a high dose, they should be very sick. And then the next obvious question that he asked was, can you show me how you use your inhaler? And here we've seen the way she uses an inhaler. Okay, so that's why it's very important. If you're prescribing these kind of devices, it is imperative on our part that we teach them how to use it. Otherwise, like she said, her asthma is getting worse, and she's using two canisters a day. Okay, but the way she's using it is totally wrong. So how to use properly use an inhaler? Hang on. So this is another video on how to use an inhaler. Oopsie. 1 minute, sorry. So I'll pause here. So what is mentioned here, if you see, put your inhaler in your mouth, press the inhaler and start breathing in at the same time. Now, if you were to use a metered dose inhaler in that fashion, okay, directly, you need to have a very good coordination between your inhalation effort and the moment you press. If that does not occur simultaneously, okay, there's a high chance that the medication may in fact get pushed back and escape from here. It may escape from the sides of your mouth, okay, or it may just stay in your mouth and not go in. So to overcome this is where you have the spacer device, where we attach the inhaler to your spacer. You then you press it, the drug remains in the chamber of the spacer, and then the patient can inhale at their own frequency. This is mainly for the elderly, especially COPD patients, where with age, your hand-eye coordination it sort of decreases. So because this using an inhaler directly requires a lot of hand and eye coordination. So that is where the spacers come in. And the problem is adding a spacer, you're just adding volume to your device. So a small inhaler, which is this much, you add a spacer, it becomes this big. So to overcome that, now we've come up with those breath-actuated inhalers. So breath-actuated devices are essentially an MDI like this, is essentially an MDI like this. But instead of pressing it, the inspiratory effort that you generate, okay, the inspiration, the sucking effort that you give, that triggers the device and then it releases the medication. So it does away with the pressing part, because the most difficult part here is simultaneously pressing and inhaling. Okay, but essentially this is what how we use an inhaler. We will continue. Again, so this is a very important. Statement here. If you're using any corticosteroids, most of your asthmatic patients will be on corticosteroids, inhaled corticosteroids. So it is a must that you have to. The reason why you're saying this is that any steroid in your oral cavity they're going to cause a local depression of the immune system there, which can lead to a lot of fungal infection. We have seen very bad candidiasis and other fungal infections all the way from the mouth down to the esophagus, mainly because of inhaled corticosteroid use, and these patients were not advised to rinse them out. Okay, so you rinse them out after this thing. You always tell them to rinse them out after using inhaled corticosteroids. How do we get this guy out? So this is in brief the summary. Remove the cap, shake the inhaler, hold the inhaler, index and thumb, sit straight, tip your head back, breathe out. Firstly, you have to exhale completely, inhale the medication. For elderly people, you tell them to use a spacer device. Here's where you tell them to use a spacer device. Hold your breath for at least 10 seconds. And then, if you have to take 2 puffs, repeat the entire steps once again. Okay. So that is how to use your inhaled medications, your MDIs. For breath-actuated devices, is the same thing. The only thing is that the inspiratory effort that you generate will cause the device to activate and push the medication. Okay, so next week I will be covering on the other drugs that we use for asthma, especially when do we use oral steroids, when do we use your anti-IgE, anti-IL-5, then other modalities of treatment, which may be non-pharmacological, your immunotherapy, your SLIT, SCIT, all that we'll just talk about, including one of the latest modalities, which is bronchial thermoplasty, which is a bronchoscopic procedure. Then we look at management of exacerbations, asthmatic exacerbations, and acute severe asthma. What are the different types of acute severe asthma? And then probably once we're done with that, I will just basically give a brief summary on the overall management of asthma. Okay, so hopefully we'll see you next week. Thank you very much for today. Hopefully by next week or sometime later, we should be, if things improve, then probably we'll be going back to classroom classes. I know this way of classes is boring. It's boring for me. I don't know about you guys, but I really find it boring for me. But let's see. Hopefully we should be getting back to online classes, offline classes again. Okay, thank you very much.
Thank you, sir.